In the beginning was the Word, and the Word was with God, and the Word was God.
I can hear you.
Okay, so that works. Okay. All right, Jacob, Meredith, do the slides move?
I'm not seeing it.
Slides aren't moving, all right? We'll try this again.
Yeah.
All right, are they moving?
Still not
Nope.
seeing it.
Yeah,
And
it's
you
not.
have to print it out
Yeah, I do.
and just follow along.
Works for me.
I'm not a magician. I don't know how to fix this.
Look real quick and then I can give you name. Nice, Sue.
Right. Yeah.
Okay, thank you.
All right, gang. It's time to start. And we have no picture. Okay, one more time. There, now we have a picture. All right, circulatory system. After I give you a quiz, which is still in my mailbox.
Doing? Well, you were you?
I thought people did say something.
That's first, gang. Then we'll get started. All right, now we get started. Okay, so the largest vessels in your body and the most muscular are the arteries. Biggest one, of course, is the aorta. Arteries come in large arteries, smaller arteries. Some books use this term branching arteries. That just means you're branching from a bigger artery to a smaller artery. Those arteries branch into arterioles. Arterioles are the vessels that regulate blood pressure the most. From the arterioles, you pass to a kind of transitional vessel that then becomes a capillary. And the capillary just has the one cell thick tube essentially. No muscle, it can't contract or dilate. It's also made to be leaky. So it will leak fluid, it will leak some protein, can't leak cells. So it leaks only relatively small things into the interstitial fluid. And then from the capillaries, they will fuse back into venules. The venules will fuse into small veins, or sometimes called minor veins. And then the minor veins fuse into the major veins, which then fuse into the biggest veins, the vena cavae, which there's one that drains the head and upper extremities, that's superior vena cavae, and one that drains the lower extremities and the trunk, that's the inferior vena cava, and those then go to the right atrium of the heart. You can always tell an artery in a cross section because in terms of percentage of the vessel, that smooth muscle is going to be greater than a vein. Veins will have some smooth muscle, but they have less smooth muscle. Veins are also going to have little valves, little one-way valves that are going to prevent blood from backing up in the vein. Arteries won't have those one-way valves. Those one-way valves, as you get older, may start to become incompetent, and you may start to get blood that starts to pool in a vein, and that vein may then start to enlarge. There's usually on the surface, and that gives rise to what are known as varicose veins. Varicose veins will tend to run in families. So the blood, if you take blood and you centrifuge it, in a tube, you'll get a layer, and about 55% of it is going to be liquid. That liquid is called blood plasma. So that's the non-cellular liquid part of blood. About 45% of that by volume will be erythrocytes. By erythrocytes, we mean red blood cells. And then sitting on top of the red blood cells, less than 1% is something that's grayish looking, and it's called the Buffy coat. Obviously named after Buffy the Vampire Slayer. No, obviously not. And this consists of your white blood cells and platelets, and that's less than 1%. So when blood gets to capillaries, there's pressure pushing the blood through the capillaries. That pressure will cause plasma to escape from the capillary. It's something like what you get feedback for. Now, the attachments between capillaries are intended to be complete. Capillaries are leaking. And as you have arterial pressure, pushing the blood through capillaries, some of the plasma will escape into the interstitial fluid. Becomes now an interstitial fluid. That's going to bathe cells and tissues. That's very important. As you relieve the blood of liquid, and you don't relieve the cells, cells cannot fit through these holes, the oncotic pressure of the blood is going to increase. So as the blood flows, when it gets to the venous side of the capillary, that blood plasma is now going to have a tendency to return to the capillaries. Now, does all of it return? No, but most of it returns. Over 90% of it returns. So you have somewhere in the vicinity of 7% of it that doesn't return. If you don't have a mechanism for this plasma to return, you're going to get lots of swelling in your tissues, and eventually you're going to completely deplete your blood of fluid, aren't you? So there is another system of vessels to return this fluid, and it's called the lymphatic system. And whatever's left here is going to flow into the lymph and will return to the blood, to the lymph. Because the lymph eventually will drain into the blood. Drains into the so-called thoracic duct, which comes up this way, and then it will drain into the subclavian and brachial veins that then lead back to the heart. Lymph vessels don't have any muscular smooth muscle. They have valves, just like veins do, and they're also interrupted by little way stations that act as a surveillance system called lymph nodes. And these lymph nodes are loaded with immune cells that are going to sample things coming through the blood and determining if that's foreign or not foreign. If it's foreign, it will mount an immune response to it. So, let's say, all right. Let's say Ram goes and gets his flu shot.
Why does that make you get
Because he's immune to the flu now, he won't get something else. Right?
I guess, yeah.
Well,
Yep.
he's immune to a couple strains.
If they pick the
So
right
we're doing
strain.
that strains because the southern hemisphere's flu season is ahead of us. That's how we know which flu strains to make our vaccine. Okay, so he goes and gets flu. Oh, how's a flu shot given? You take it by mouth, you bend over and take it that way, you get in the arm, how do you take it?
They used to give them
Yeah,
up.
Ram, what do you think?
Yeah, but normally now you get it where? In your arms, you get it intramuscular. Is your muscle a tissue? Right. So is the muscle drained by lymph? Sure. So within that, usually the flu is an attenuated flu strain. It's grown and it's attenuated, so it won't give you the flu, despite what you read, but from morons on Twitter. The flu then will come in here and will infect cells called dendritic cells and you'll take it to cells in the lymph node. So at the shoulder, they'll probably take it to the axillary lymph node. And it's there that you'll mount an immune response to it. And within 2 weeks, usually, you'll have a robust immune response that then renders you resistant to those particular flu strains. So that's what I mean when we say plasma. A cellular liquid part of blood. And lymph is essentially the returning of that interstitial fluid, at least a portion of it, back to the blood. All right, questions? Any of that? Let's talk about blood components. So the average size adult, what's average size? Average size adult would be, if you're a guy, it'd be something like 5'10", 5'9". If you're a young lady, it'd be something like 5'6", 5'7". So if you average those two, you're gonna have in the vicinity of 5 liters of blood. So is John gonna have more blood in his body, say, than Corinne? Yeah. He's a bigger dude, he'll have more blood per volume than Corinne will. No, Rem will have more blood because he's a guy. Yeah.
Typically have more blood.
Yeah, because they're typically bigger and they have more red blood cells because of testosterone. All right, so the ballpark number is 5 liters, give or take 250 milliliters or so. And it's in the vicinity, it's close to 10% your body weight, close to it. So it's the number is usually maybe 8, 7.8 or 8.3 or something like that. That's the ballpark number. About 8% of your body weight.
Can your family have more blood?
Yes, but not that much more. Now, arterial blood, when you see it on a drawing, will always be drawn in red. Venous blood will always be drawn as blue. Now, is venous blood blue? No. If it looks blue on the back of your hand where your veins are, that's a trick of light. That's refraction of the light, and it looks blue because of light refraction. If you put blood in a test tube and withdraw all the air, the blood will change color, but it will not turn blue. It'll turn a brownish red, but it will not turn blue. So people who say venous blood is blue, that's incorrect. But in anatomical convention, venous blood is drawn as blue. So hemoglobin, which is contained in red blood cells, is again designated as red in arteries, designated as blue in veins. In arteries, most of it will be bound to molecular oxygen. So that's so-called oxyhemoglobin. Just regular hemoglobin, you don't need to call it deoxyhemoglobin, just hemoglobin. It will be predominantly without oxygen in veins. Now the exception is going to be the venous blood that is going to return the blood from the lungs to the heart. That particular venous blood will be oxygenated. That's the only exception. Also, the arteries taking the blood from the heart to the lungs, they will be largely deoxygenated. So plasma is 90% water. The rest are proteins, electrolytes, and dissolved gases. Proteins, electrolytes, and dissolved gases. So the proteins will constitute 7 to 9% of the plasma by weight. There's 3 types. There's albumin, and then different types of globulins, and then fibrinogen. The most abundant blood protein by far is albumin. You could say the stark majority of all plasma proteins are albumin. It's made in the liver, and it's responsible for oncotic pressure. Oncotic pressure, very simply, is the force that helps keep water in the bloodstream. The force that helps keep water in the bloodstream. Now, if you are starving and your albumin goes down, your oncotic pressure goes down. So blood is going to tend to leach water into the tissues, and it's not going to come back. So what's that going to happen? What's now going to happen to your tissues? They're going to fill up with water. So your belly is going to bloat. That's called ascites. And when you see pictures of kids on these World Vision websites, they have bloated bellies. That's a sign of starvation because they can't make albumin because they don't have the nutrients to make it. So the blood oncotic pressure is low. So they leach fluid now into primarily the abdominal cavity. That's ascites. Ascites is also a sign of chronic liver failure. So you see it in people with alcoholic cirrhosis. You see it in people with non-alcoholic cirrhosis. Do you know what cirrhosis is? No? Professor usually has us in the he used to study cirrhosis. Well, it's a knight. His name was Sir Osis. And so, yeah. Cirrhosis is a fatty liver. A fatty liver. The liver tissue is scarred, and because it's scarred, it's replaced with fat. So the liver is failing. You see this in chronic alcoholics. You see this in people with chronic hepatitis B infections. You see this in people with hepatocellular carcinoma, advanced hepatocellular carcinoma. You see this in people with liver cancer. That's a result of spread from other cancers. For example, breast cancer very commonly will spread to the liver. You see this in so-called non-alcoholic fatty liver disease, so-called steatohepatitis. Most people will also show ascites. And they have ascites because they can't make albumin. Because what makes albumin? Liver. In fact, the liver makes most of your blood proteins. It makes most of your blood protein. Now, the globulins, most of these are carriers. They're going to carry hormones. They're going to carry particular types of vitamins. So they're transporters and what have you. Gamma globulins are not made by the liver. They're made by B as in bummer, B lymphocytes. B lymphocytes. They are antibodies. They bind foreign substances and they mark them for destruction. Your alpha and your beta globulins, however, are largely transport proteins. They transport fat-soluble vitamins, hormones, metal ions, fats, things like that. Then a protein that's very important for blood clotting, called fibrinogen. It's 4% of the total plasma protein, and it's the last step of blood clotting that converts fibrinogen to fibrin. So it's a precursor for fibrin, which will reinforce platelet plugs, which we'll get to in just a bit. So electrolytes will include mainly sodium, calcium, bicarbonate, chloride, and potassium. The electrolytes will play a really vital role in the acid-base chemistry of the blood. They'll regulate blood osmolality and overall concentration in the blood. Then you'll have other solutes, hormones, glucose, and then respiratory gases like oxygen and carbon dioxide. We talked about how blood volume is controlled. Remember, you have osmoreceptors in the hypothalamus. When they detect an increase in blood osmolality, they will increase the sensation of thirst, and then they will stimulate the posterior pituitary to release ADH. That will increase water retention by the kidney. So you decrease water loss, increase water intake. That will dilute the blood, and your osmoreceptors then won't be activated anymore. Nice negative feedback loop. Any questions about plasma? Let's now talk about cells in blood. Cells in blood are often called formed elements. Formed elements. As we said, they constitute around about 45% of the blood volume. All right, so the percentage of red blood cells in the blood is called the hematocrit. Hematocrit. Hematocrit can be a pretty important number. Let's say you've got, patient who comes in, they had stab wound, let's say. They're bleeding out. You manage, say, to staunch the bleeding. They've lost volume, so you stick an IV needle in their vein. You pull that volume back up, but now you've got the volume the same, but the number of red blood cells are down. Blood volume will be normal, but the hematocrit will be low. In a case like that, they may need fresh packed blood. All right, so the main element, main formed element in the blood are the erythrocytes. And a cubic millimeter of blood will contain quite a few erythrocytes, between 5 and 6 million per cubic millimeter. But it's only going to have about 5 to 9,000 white blood cells, leukocytes. So here are the three, well, 7 different cell types you're going to see in blood, the formed elements at least. So the erythrocytes, that'll be the most numerous. Then your white cells, your leukocytes, well, WDCs, leukocytes. They're going to fall into 2 categories. There are those that on a hematoxylin and eosin stain have very ovulous little bags in the cells called granules. So these are called granulocytes. Granulocytes. Then you have cells that don't have discernible granules. They are called agranulocytes. Granulocytes, agranulocytes. So the granulocytes consist of neutrophils, eosinophils, basophils. Neutrophils, eosinophils, basophils. Now the eosin stain of the hematoxylin eosin stain is sensitive to pH. It is acidic. It looks a beautiful, bright, gorgeous pink. If it's basic, it turns kind of a dull purple. So the eosinophils have beautiful acidic granules. The eosin stains are granules of bright pink. When you see an eosinophil under an H&E stain, it screams at you. You can't miss it. It's a cherry pink. Okay, cherries aren't pink, but if the cherries were immature, it's a cherry pink. Basophils. Eosin stains their basic granules a dull purple. They're basophils. Then you have the, I can't make up my mind, neutrophils. Their granules are neutral. So they will stain kind of a very dull gray. So neutrophils, neutral granules, eosinophils, acidic granules, basophils, basic granules. Then lymphocytes, monocytes, you don't have detectable granules. Platelets are really dinky, and if you can't spot those in an H&E stain, get a new job. Because they're so small, you just can't mistake them. They're pretty small and dumpy looking. That's a platelet. So erythrocytes are shaped like little biconcave discs. Do you remember the old checker sets? They used to come with checkers that had, they were puckered like this on both sides. That's kind of what an erythrocyte is like. It's got little it's dished on both sides. So it's biconcave. So if we were to draw the erythrocyte on the end, it would look kind of like this. So it's biconcave. It's like somebody put their thumb on it and gave it a push inside. Now, this depressed center makes them flexible. They're flexible enough to fit through even the smallest blood vessels. This also increases their surface area, so you get increased gas exchange. And that is precisely what these are for. Erythrocytes, as they mature, they dump their organelles. They have no nuclei, they have no mitochondria, they have no endoplasmic reticulum, they're chock full of hemoglobin. They're packed to the gills, if they had gills, with hemoglobin. And that's what they're for. They carry oxygen to tissues from the lungs, carry waste carbon dioxide to the lungs and then load up with oxygen and then go back to the tissues and so on and so forth. Incidentally, brainstorm with me, please. Let's say a patient comes in and their hematocrit, instead of being 45%, is 52%. What might cause that? Guys, it's staring you right in the face. The over-oxygenation won't do it. What happens,
Yeah.
sorry?
Can you say it one more time?
What happens, say, if your hematocrit's not 45, let's say it's 55. What might cause that? No. What happens if the amount of water in the plasma?
You're dehydrated?
Ah, dehydration, exactly right. So an increased hematocrit would be a sign of dehydration, wouldn't it? And a decreased hematocrit might be a sign of anemia. So the red blood cells are very, very good for gas exchange. But the fact that, yeah,
Out of curiosity, then, if you are someone who's anemic and dehydrated, what happens?
you probably pass out.
Oh. Yeah, but what about the hematocrit levels?
It depends. Some people, my mother, for example, who had myelodysplasia, mom depended on blood transfusions. And mom got to the point where she was so used to being anemic, her hematocrit could get down to 28%, and she was still conscious because she just kind of got used to it. Now, granted, she was short of breath, and what she said often made no sense, but she was still up and around and what have you. But we knew that something was going wrong.
And the same happens with dehydration, like if you're at a low level.
Oh, yeah. Yeah. In fact, when you get blood, they want you to sit there for a bit and have a drink because it's not uncommon for some people after they give blood to walk out the door and then pass out because they've lost a lot of fluid. So that's why they're trying to get you to drink and what have you and have a root beer float and whatever else. Now, since erythrocytes don't have organelles, they don't last that long. So they live only about 120 days. After that, the lipid in the membrane starts turning over, and a lipid called phosphatidylserine now starts to become concentrated on the surface rather than on the inside of the membrane. And in the liver and spleen, there are stationary cells. In the liver, they're called Kupffer cells. In the spleen, they're called reticular cells. These cells have receptors for phosphatidylserine, and that's how they tell if a red blood cell is too old. If they bind the red blood cell, they gobble it up, and they destroy it. They recycle the iron, they recycle the amino acids, but the red blood cell is kaput. It's finite. It's done. So your bone marrow has to be constantly replacing red blood cells. Let's talk a bit about hemoglobin, this protein that fills the red blood cell. There's lots and lots of copies of hemoglobin in the red blood cell. That's what gives it this beautiful red color. Hemoglobin is a protein that has 4 polypeptide chains. 2 of them are called alpha globin polypeptides, 2 are called beta globin polypeptide chains, and then there's a flat iron-containing heme group. And the heme has an iron in the center. The iron is the business end of this molecule, and it binds molecular oxygen, loads up with it in the lungs, and then it will release it when it gets to the tissues. Hemoglobin is actually able to transition from a state that likes to bind oxygen to a state that likes to release it. And when it gets to the lungs, it gets to the, oh, give me oxygen version. When it gets to the tissues, it gets to the, oh, go away, you tissue, and then loads up with CO2. So here's the structure of hemoglobin, the little flat red things there. That's the heme. The iron is the discolored thing in the middle. That binds the oxygen. Here's the structure of heme chemically. The oxygen binds like this. And the hemoglobin has, again, an increased affinity for oxygen in the lungs, decreased affinity for oxygen in the tissues. And then when it goes back to the lungs, it transitions back to that high affinity state. And it's able to do that because it has multiple subunits. Any questions about red blood cells? Let's go then to the leukocytes. The leukocytes. So leukocytes have the ability to leave the blood and enter tissues because they're capable of amoeboid movement, and they can signal to the endothelial cells to separate and let them through. That process is called diapedesis. Diapedesis. That's how they're able to get to sites of infection during inflammation. So we talked about granular, agranular. This is with a hematoxylin eosin stain, very common stain that's used for tissues, for blood cells, things like that. Very easy stain to do. I could show you how to do it, and you'll know how to do it. It's very easy. If you have granules with that stain, you're a granulocyte. If you don't, you're an agranulocyte. Hematoxylin eosin stain. So your basophils, again, have the blue to purple staining granules. Red to pink staining granules are the eosinophils. Eosinophils go up during allergies, and they go up if you're infected with metazoan parasites, i.e. worms. If you have a worm infection, eosinophils surround the worm and release their granules, and they damage the worm and eventually kill it. And sorry? Yep. If you get infected with a metazoan parasite, the eosinophil numbers go way up. Also, if you have certain types of allergies, they go way up too. Basophils. Basophils, when they're born, they will tend to move into tissue and then will tend to become stationary. They will tend to release their granules when they sense that something, tissue is damaged, something's invading the tissue, something like that. Their granules will contain things like histamine and other types of immune modulators and things like that. Neutrophils are the most common of the leukocytes. Some 60% of the leukocytes are neutrophils. These are the first responders to an infection. When they're born, their nuclei are long, like a sausage, and they're called band cells. Band cells. Once they mature, the nucleus gets very lobed, and they get called polymorphonuclear cells, which are mercifully abbreviated PMNs. These cells are so-called professional phagocytes. Professional phagocytes. So they gobble up invading bacteria and also gobble up cell debris. So these are your early responders. Your early responders. So this, to use a baseball analogy for our baseball friends in the back, these would be your starting pitchers. These guys come in hard and they burn hard, which means you better have a bullpen. We'll get to the bullpen here in just a bit. The agranulocytes come in two types, lymphocytes and then the bigger monocytes. Lymphocytes and then the bigger monocytes. Lymphocytes typically are smaller. They also have very, very big nuclei relative to the amount of cytoplasm. They have a very large nucleus to cytoplasm ratio. There's two types of lymphocytes, well, three actually. There's two main ones. T cells, these make antibodies. T cells. They will mature in the thymus after being born in the bone marrow. The third lymphocyte is called a natural killer cell. Or an NK cell. Natural killer cells will kill standard dying cells, virus-infected cells, and cancer cells. These cells play a huge role in the adaptive immune response. Monocytes are large cells. They have a cell that the nucleus can be kind of shaped like a comma. It can be horseshoe shaped, but it's a non-activated monocyte usually just has a comma-shaped nucleus. When a monocyte is activated, it becomes known as a macrophage. The macrophage. It is a professional phagocyte. It's also a regulatory cell. It regulates the immune response. And so this is your bullpen. These guys come in after the neutrophils come in. Neutrophils work very hard. They get burned out very fast. Then the macrophages come in. So they're your middle relief. Then you have platelets. Platelets bud from larger sites, larger cells in the bone marrow called megakaryocytes. They have no nuclei. They don't survive very long, 5 to 10 days. They vary in numbers, you can see here. 130 to 400,000 or so per milliliter of blood. They can move via amoeboid movement. and they are involved in clotting. They help staunch the loss of blood when a vessel is damaged. They do that by forming a platelet plug, and that's what we're going to talk about next. Let me pause here, see if there's any questions. No? All right. Now, let's say you have water flowing in a pipe. Let's say you get a breach in the pipe. Water now starts to leave the pipe. You're losing water. Water stretches. How are you going to fix that pipe? You're going to build a brick wall. The platelets are the bricks. A brick wall, and you're going to reinforce the bricks with mortar. The mortar is the fiber. So staunching bleeding, this thing called hemostasis, consists of two processes: building a brick wall and reinforcing the bricks with mortar. Let's talk about the brick wall first. So the innermost layer of the artery is lined by a single layer of cells called an endothelium. Endothelium. Those cells here that have been drawn here like this, that is an endothelium. All right, let's say, okay, pick on somebody else now.
Yeah.
Aaron. Let's say Aaron invites Rem and Corinne and Amanda over, and she's going to cook for them. So she's going to make, okay, filet mignon. So that is a good deal of cutting if you ever made filet mignon. Let's say Aaron cuts her finger. Now the knife is going to slice through several layers of tissue.
The whole thing. My knife. You enjoy it?
Now, right, yeah, she just spiced up her filet mignon. Yeah. Anyway. Now, outside the vessel, you have fibers of elastin. You have elastic fibers. You also have collagen. Collagen is a major structural protein in humans. The fibrous layer surrounding the vessel supports it and protects it. So the first thing that happens when you cut your finger is endothelial injury. Endothelial injury. So the smooth muscles that surround the vessel, they detect an injury, and that injury will cause a reflex contraction of the vessel. That is meant to decrease blood loss. This is also called vascular spasm. Vascular spasm. Now, the endothelial layer, normally, I'm going to skip this and go to, I'm ahead of myself. All right, where's the picture? Where's the picture? Where's the picture? I don't have the picture. I took the picture out. Bummer. Okay, anyway. The endothelial layer normally secretes nitric oxide, and it secretes a prostaglandin called prostacyclin. Nitric oxide, prostacyclin. When there is endothelial injury, you have decreased secretion of nitric oxide and prostacyclin. Then, because you've damaged the endothelial layer, you've exposed the blood to collagen. So that's your first step, damage. Second step is exposure. The damaged endothelial cells then release a protein called von Willebrand factor. Von Willebrand factor. That's going to bind to the exposed collagen. Now we have step 3, adhesion. Step 3, adhesion. Platelets have a receptor on their surface for von Willebrand factor. It's called GP1B, for those of you who are interested. They bind to the exposed collagen with their receptor. Now the platelets, as they bind now, are going to start to clump together. So step 1, damage. Step 2, exposure. Step 3, adhesion. Step 4 is activation. Activation. Activated platelets, when they're bound to von Willebrand factor, will take their little granules and they'll dump them. The other thing that happens to activated platelets, they change shape. They start to go from round to star shaped, and they start to make little tentacles. The tentacles now express receptors that allow them to grab other platelets and pull them in. They also will secrete ADP, and ADP is a platelet activation factor. So they grab other platelets and they activate the other platelets by secreting ADP. Then they secrete an additional platelet activator called thromboxane A2, which is a fatty molecule. And this is the so-called platelet release reaction. Platelet release reaction. So now more and more platelets, as they get activated, they will now activate other platelets. It snowballs. It snowballs. And as they snowball, the platelets now express this receptor. It's called GP2B3A that allows them to bind each other. And that is step 5, the final step, aggregation. Aggregation. And so the platelets stick to the collagen because collagen have von Willebrand factor. They stick to that. They stick to other platelets. They activate each other. And then they aggregate. You've now built a brick wall. Next time, we're going to look at how you put the mortar in between the bricks. We'll look at coagulation. Have a great weekend. I'll see you guys on Monday.
Hey, Dr. B.
Yeah.
Just out of curiosity, for the next exam, do you know what chapters it is yet?
Not yet.
Okay,
I'll let you know.
sounds good. Okay, thank you.